Hello, my name is John Marshall from the Lombardi Comprehensive Cancer Center, and thanks for joining me again on our Medscape web blog, really focused on GI tract cancers. Colon cancer today is our topic, and the hottest thing that's going on in colorectal cancer today is the whole story about EGFR blockers and the KRAS mutation. So let's back up a little bit. We know that very many cancers are driven by the epidermal growth factor receptor and its ligands binding, causing signaling through the cancer cell, driving that cancer cell on to do all those bad cancer things of division and growth and invasion. And we've also known that among other cancers, colon cancer is one of those diseases that's responsive to EGFR blockade. And several medicines have emerged which in fact block the EGFR receptor. And the two that have primarily played out in colorectal cancer are the monoclonal antibodies cetuximab and panitumumab. Well, a series of large clinical trials have been done incorporating these drugs, either as single agents or in combinations with chemotherapy. And what's clearly been shown is that a small benefit, 10, maybe 15% benefit, was demonstrated when cetuximab or panitumumab was added or when used in patients with metastatic colorectal cancer. The problem has been is figuring out who benefits from these drugs. Now, to get into these clinical trials initially, all patients had to have was a tumor that expressed the epidermal growth factor receptor. Makes sense, right? So if this antibody is going to work against the cancer, you got to have the receptor present. So the entry criteria focused on the EGFR receptor. Well, it turns out that that is not the right thing to measure. When one thinks about signaling, I like to use the example of your car. So the signal or the receptor out on the cell surface is sort of like the gas pedal in your car, and the nucleus and the engine driving all of this is sort of like the throttle or the engine part of your car. Well, when one pushes the gas pedal, at least in my car, there's a lot more that happens than a direct connection from the gas pedal to the engine. There's a lot of stuff in between. And one of the key things that's in between is a molecule known as KRAS. And it turns out that about 40% of all colorectal cancer patients have a mutation in their KRAS gene. In essence, the KRAS gene is stuck in the on position. So you can do whatever you want to the gas pedal. The engine is still going to rev because something inside the engine is stuck in the on position. So this blew up everything. It changed everything. 3 large clinical trials, which had already been presented, underwent a retrospective analysis. The first one, presented almost a year ago now, was the pivotal study for panitumumab, where half the patients got no treatment and the other half got panitumumab, an Eastern European study where they had access to essentially all of the tumor that they needed from this trial. And they showed very nicely that the 40% of patients who had a KRAS mutation had no benefit from the addition of panitumumab. And in the group that had wild type or a normal functioning KRAS, the response rate doubled to nearly tripled. Now, not everybody over there who had a normal KRAS had a response, but it clearly weeded out the patients who were not going to respond. And this was really the first signal. 2 other large important trials also published the same thing. A study known as the OPUS study, which looked at FOLFOX plus and minus cetuximab, and then the most recent CRYSTAL clinical trial, which was FOLFIRI plus minus cetuximab. Both of these clinical trials showed the same thing, that if you had a KRAS mutation, you did not benefit from the addition of the EGFR blocker. And if you had a KRAS which was normal, your group was much more likely to benefit, not proving that you'd benefit, not establishing benefit, but again, weeding out those who wouldn't. So when one thinks back on this, we've been, frankly, swimming in a sea we didn't have much direction in. Now this splits colon cancer into two separate diseases. Just like breast cancer is three diseases at least, based on estrogen receptors, based on HER2 receptors, and based on triple negatives. Colon cancer, which was one big disease, is now at least two diseases around the KRAS gene. If you're wild type, you're probably in metastatic disease, you're probably going to get an EGFR blocker at some point because you're in the group that's more likely to benefit, sort of like Herceptin in HER2 overexpressed patients. If you're a mutant, if your patient has a mutant tumor, then you really shouldn't be giving these people EGFR blockers, just like you're not giving Herceptin to patients with breast cancer who are not HER2 overexpressors. So colon cancer became two diseases at ASCO this year, all around the KRAS mutation versus wild type. And it's going to change everything, all the clinical trials, the NCCN guidelines, insurance coverage, and the like. So look out for this. You're going to have to start measuring patients with tumors for KRAS, and it will influence what you do with them from here on out. Thanks for joining me.